A couple of announcements before I introduce our speaker, who is not a guest speaker. In fact, he's a member of our own family, as well as that of Pediatrics. So we're happy to have Dr. Lee here today. But before that, let me just announce, as I did on Tuesday for the faculty meeting, that Dr. Ralph Paris has become the new Chief of Medicine at the VA hospital. The other thing that I wanted to mention is today is an interesting day because it was the birth back in 1899 of Percy Julian. I don't know if you've heard about Percy Julian. And Dr. Julian was an African-American chemist. He holds 100 patents because of the synthesis of hormones. He synthesized cortisone and a number of other products from soybean. And in fact, his synthesis methods have been used for many years to develop production of a number of hormones, just like progesterone, testosterone, and cortisone for drugs. In 1950, remember, he was an African American, and he lived in an all-white neighborhood. His house was bombed and burned. It's also the day of Maurice Hilleman. She died on this day back in 2005, just a few years ago, at age 85. And that's important today because today is all about immunity. And Dr. Hilleman was an American microbiologist who developed a number of vaccines against many diseases, and I was unaware of this, including mumps, measles, rubella, chickenpox, hepatitis A and B, pneumonia, meningitis, influenza. He had a career of 40 years where he developed about a dozen experimental and licensed animals and human vaccines. The writer of his biography stated that although Jonas Salk, Albert Stein, and Louis Pasteur received much public recognition, it was Hilleman's work that probably responsible for saving more lives than those of any other scientist in the 20th century. A big deal, and all about immunity. And with that, I'll leave you with the Section Chief for Allergy Immunology, Dr. Tao Lee, who's going to introduce our speaker.
Good morning. Thank you. Thank you, Dr. Roman, for the introduction. Many of you folks already know Dr. Gerald Lee, but he still has that shiny look on him a little bit. So I'll just say a few words of introduction for Dr. Gerald Lee for the few that do not know Dr. Lee. Dr. Gerald Lee is graduated from Case Western Reserve University Medicine, and then he did his combined internal medicine and pediatrics residency at St. Vincent's Hospital in Manhattan in 2007. He stayed on an extra year to do a chief residency and in pediatrics before starting his fellowship in allergy immunology at Cincinnati Children's Hospital Medical Center, where he did work under Dr. Gurjit Hershey in particulate diesel pollution and so forth. Dr. Lee joined our faculty at the University of Louisville in 2011, and he currently has joint appointments in both pediatrics and medicine. And he is the first-time allergist ever at the university. Dr. Lee's clinical responsibilities including managing the University Allergy Clinic, which is at our Gray Street building, where he's there 5 days a week, as well as staffing the Immunodeficiency Clinic along with the Infectious Disease section in the Department of Pediatrics. His primary academic interest, which is dear and dear to my heart, is medical education. He is currently enrolled in the University of Cincinnati doing a Master's of Education, and he is Vice Chair of the Continuing Medical Education Committee for the American College of Asthma, Allergy, and Immunology, and he also serves on various committees in the American Academy of Allergy, Asthma, and Immunology as well, too. And so with that, I'd like to welcome Dr. Jerry Lee.
Thank you very much, Tao. I appreciate it. Again, it's a pleasure to allow myself for you to invite me to speak. We're going to talk about a topic we typically think is a pediatric-based topic, and I hope by the end you appreciate that it's something you definitely will encounter in your clinical practices. So therefore, arming yourself to recognize the signs will be critically important and actually change patients' outcomes. And so, the aphorism, when you hear hoofbeats, don't go looking for zebras, is attributed to Dr. Woodward. He performed incredible work on typhoid fever that got him nominated for a Nobel Prize. And so we do know the principle of Occam's razor, that you really want to think of something more common, something more prevalent. But when you are charged with something that's rare, how can you pick up the signs? And so what would be the hoofbeat in this situation? And this is someone you see in your clinic, a 23-year-old man Again, coming back in for antibiotics. He has sinus symptoms, facial pressure, headache, nasal congestion, cough. They always have the come back to Louisville story. I get that story a lot in my clinic, I'm not sure why. And he says he's had recurrent sinus infections, bronchitis, pneumonia, and frequent courses of antibiotics. Now, I'd like to have some participation for the audience. So if you have a smartphone and you could go to your web browser, there is a website called pollee.com, completely anonymous. I'm not detecting your phone or whatever, but I think it would be really nice for you to participate. So this is the kind of the warm-up question. So you see someone like this, and immediately when you hear that stem, you guys have thought of a diagnosis that is most likely. And that's kind of like how we do heuristics, right? We basically see something jumps to mind, and we just kind of go there and we confirm we're right, or maybe there's something else going on. And so what's your heuristic mind telling you? What would be the most likely diagnosis in this scenario? And is there a mouse? Right, very good. So I have one total result, so that's fantastic. Maybe we could go up to 5. And then as people kind of try this out, maybe we'll get more responses. So let's, if we could get
It's
2.
not American Idol.
That is true. That is true. Oh, wonderful. Excellent. Well, you can continue the vote as I show the polling results, just so I could, this is kind of the warm-up question. 57% said common viral immune deficiency, and again, that's very interesting because obviously every person with recurrent sinusitis and pneumonia, I'm very surprised if you are looking for a common viral immune deficiency. That makes me very happy. But again, there's other possibilities, right? And let's think about them. So we're gonna have to. So let's play likelihood. Adults get about 2 to 4 URIs a year. Maybe he just has a snotty kid and getting a lot of URIs. Allergy, they put the prevalence as much as 1 in 20. And so certainly allergic rhinitis and asthma could be involved. Cystic fibrosis is usually thought in the range of 1 to 3,000 to 1 to 15,000. Wegener's would be something like 10 to 20 in a million. So where does CVID and immune deficiency lie in all this? And so hopefully that's the first question I'd like to answer for you. And so I'd like to kind of review some of the epidemiology of immune deficiency. And so you can recognize some of the features of when to start thinking about it. When you see this kind of sinusitis or something very common come in and out, when would you grab onto something and say this deserves further workup? And then how would you get the ball rolling? And so, and again, I'm not going to be talking about any products when I make disclosures for this talk. So when I say primary immune deficiency, obviously I'm implying that the immune system defect is extrinsic. So, what I'm not talking about is HIV or some sort of medication like chemotherapy. I'm not talking about, uremia or diabetes or some sort of protein-losing enteropathy. I'm really implying that there is some sort of inherent genetic defect with the immune system. And the first immune deficiency was described in 1926. By 2 gentlemen, Salawa and Henner, who described 3 adolescent Czech siblings with chorioathetosis and ocular telangiectasia. So I'm sure some of you recognize this condition. This is ataxia telangiectasia, which is the first actually written described primary immune deficiency. So going from 1926 to 2013, we have about 150 or something. So I did my job. I've showed you the immune deficiencies. And so this is the end of the talk, and we can all go, right? So, obviously we're going to get more information. This is overwhelming and super rare. So how can we sort through this? So this is a next question I'd like to ask you, is that I showed you that last thing, and I didn't give you an estimate for the prevalence of an immune deficiency like CVID. So if you take all comers, any sort of immune deficiency, what would you think is the estimated population prevalence? Again, this is a very difficult question to answer. The NHANES survey doesn't ask about immune deficiency, and so how can we collect this information? So maybe we can... All right. I think we'll settle around 6-ish or so. Okay, this is great. Thank you. So the majority of you estimate somewhere around the range of 10,000. Well, one study attempted to answer this question. In order to do this, what they did was they did one of those random digit phone number dialers, and they were able to reach 10,000 households in 2005. And so this represents almost 20,000 adults and 6,000 children. With the question, has anyone in your household ever been diagnosed with a primary immune deficiency? And this is not AIDS, right? So they have 23 members in 18 households. If you do the numbers, that's 1 in 1,200, all right? So again, there are limitations because, this is obviously a phone survey. This is not a physician diagnosis. But, can we rely on ICD-9 coding? It's hard to put the balance between recognition, which is physician dependent and requires accurate coding, and more of a physician-based study. So again, I'm going to say as much as 1 in 1,200. Kind of a rare estimate would be 1 in 400,000. So, I hope I'm going to convince you that it is probably a little bit more common than we thought it was. And one way we can identify who are the people we're seeing with primary immune deficiency in the United States is actually to ask them, if I only have 20 households and a handful of people, that can't characterize the United States. And so the Immune Deficiency Foundation has performed at least 3 surveys of their patient registry, asking them certain questions about their diagnosis and some features that kind of inform us what is the state of primary immune deficiency in the United States. And so about 50% of the respondents in the third survey, or 1,351, were characterized. And interestingly, the majority of the respondents were over 18, at least 60%. And so I thought that was very surprising. Again, we usually think of primary immune deficiency as a pediatric disease. And again, there might be some bias in just these surveys in terms of who registers for the registry. But again, it proves the point that this is a disease seen in adulthood. And if you think about when would they be diagnosed, 50% of the population were diagnosed at age 30 or later. So again, the adults are being diagnosed very late in life, with a quarter of them even being diagnosed at 44. We have 3% of the population diagnosed in the elderly age group. So really, we can understand that this can be an adult condition as well. So, generally, if you think about your own practice, in the last 5 years, just to kind of informally see who's here among the 14 who are participating, how many have you actually seen in your own practice? Tao, you're obviously one kind of skew the results, but anyone else? I'm just kind of curious what you're going to see. I know we're going to get to 14 past. Okay, good. So we're about split, maybe 40, 60 or so, with 40 saying, yes, I have seen someone in my practice. So what do other physicians say? Well, there was a web-based survey in 2008 where they were able to contact 1,880 physicians, where 39% of them had internal medicine certification. And of the third of the group who answered yes to the same question you did, about 30% were internists. So again, internists do see primary immune deficiency. But unfortunately, primary immune deficiency diagnosis is delayed. The Mayo Clinic have had 120,000 people they followed as a cohort for 30 years. And what they were able to calculate was an incidence of 4.6 per 100,000 person years, with the majority of them being B-cell immune deficiencies. You guys identified common variable immune deficiency as in the first case. But interestingly, the mean the mean interval between onset and diagnosis was almost 5 years. And if you look at the IDF survey, it could be a large portion state 20 years of delayed diagnosis, with CVID being the highest of the group, with a 14-year lag between the onset of recurrent infections and the final diagnosis and presumably definitive treatment. So again, there is a need to empower ourselves to recognize common variable immune deficiency in a better fashion. And again, one of the things that could be very confusing about things is that, I showed you more common conditions. Well, patients with primary immune deficiency can also have common conditions. At least 16% of the population stated they had the prior diagnosis of asthma, so you could easily chalk up things to asthma and call it a day, when really, there should be some other features that are going to ask you to dig a little bit deeper. So what are the consequences of delayed diagnosis? So again, in the same Immune Deficiency Foundation survey, at least 1/3 of the population stated that they had a permanent loss of lung function, presumably due to bronchiectasis. But certainly, they can involve any organ in terms of digestive function, vision or hearing, mobility, or neurological problems. So delayed diagnosis by the physician has a cost. And so therefore, again, that's kind of the goal of this talk. I hope I convince you that maybe not as high as 1 in 1,200, that's one study, but it's more common than we think, and it's just as prevalent in adults as in children. So, we do see it, but we don't recognize it in a timely fashion with the consequences of significant permanent disability. So again, this is the need. How are we going to address this need? So again, that's the goal of the next part of the talk. So how can we recognize the true zebras early enough, all right? So the classic thinking is, well, you have to have recurrent infections. And of course, the majority of patients with some sort of immune deficiency have infections more than usual, or an infection that was considered very unusual. And so the Jeffrey Modell Foundation brought an expert panel of immunologists to try to quantify that in a way that would be more concrete than just getting sick a lot. And some of their recommendations, again, this is expert opinion and not study, would be 2 or more ear infections, a non-allergic person with multiple sinus infections in the same year, pneumonias for consecutive years, chronic diarrhea with weight loss, some sort of recurrent viral like warts or herpetic infections, the need for IV antibiotics to have definitive therapy for infections, recurrent deep-seated abscesses, thrush or some sort of chronic fungal infection, and then infection with opportunistic mycobacteria. And finally, family history. 2 or more was considered at least one way to approach these patients and ask the question, maybe I should go digging a little bit further. Now, family history may be very reliable in children. At least that's kind of what I push in the pediatric population. But interesting in the IDF population, which again was the majority of adults, only 7 to 17% actually had a family history of immunodeficiency. So I wouldn't use family history to rule out anything. Again, patients with primary immune deficiency can have 0 family history and still have something that needs further evaluation. And so is there any ways to kind of sort through the zebras? Is there something the pattern can tell us? And so the general organization, and again, this was taken from an excellent website called Immunodeficiency Search, is to kind of divide the approach to immune deficiency by the immunological defect. And so, again, I could easily go over Janeway or Abbas for the rest of the hour, but again, this is kind of this one-slide version, just so you can get the general idea of kind of how each defect leads to the phenotype. And so, again, the most common is B cell. And B cells B cells are involved in productions of antibodies by differentiating the plasma cells after activation. And we know antibodies can tag pathogens for opsonization by phagocytes. And certainly it can bind complement to have that lyse and also neutralize toxins. Now, T cells come in usually 2 flavors. The CD4 is the general immune system. and then they can do multiple functions. One particularly important function is their effect to activate B cells for T cell independent antigens, usually protein antigens. And then CD8 cytotoxic T cells. So these are the cells that kill virally or tumor cells. Phagocytic immune deficiency, so these are your phagocytes, so they will engulf and destroy pathogens. Complement, again, interacts with antibodies to opsonize pathogens and also lyse bacteria by forming a pore called the membrane attack complex. And then natural killer cells, which again are very similar to CD8 cytotoxic cells. Again, they have less specificity, but they perform the same job. They're able to destroy virally infected or tumor cells. And again, the pattern, if you have the human knockout for each of these arms of the immune system, would be as follows. Again, I emphasized before that recurrent cytopenic infections is the signature of a B cell immune deficiency. But again, they can have other features that are less appreciated. And again, I'm going to go over some cases so we can try this in practice. Recurrent or chronic gastroenteritis. Enteroviral infections can also not have in the gut, but also in the CNS. And also they can get certain septic arthritis. For T-cell immune deficiencies, I think you are most familiar with this because you're all familiar with the secondary immune deficiency, HIV. But a primary problem of T cells presents very similarly. They will have an opportunistic infection with either a fungus, mycobacterial, or parasite, or PCP. Again, this can present as any invasive infection, chronic diarrhea, and again, immune dysfunction can always not only cause deficiency, but also some immune dysregulation, such as autoimmunity. So phagocytic immune deficiency, the classic thinking is that they present with some sort of abscess formation because of interferent clearance of catalase-positive organisms, and that can present as abscesses, lymphadenitis, or pneumonia. Or, neutropenic patients can have periodontal disease. So complement deficiency, terminal complement is the classic, is recurrent neisseral infections. But again, more of the rare complement deficiencies can also predispose to autoimmunity or pyogenic infections. And finally, NK cells, again, those affect viral infected cells, so they can get more viral uncontrolled infections. That could be herpetic infections, or problems with certain viruses like mononucleosis can lead to a syndrome of extreme immune activation called hemophagocytic lymphohistiocytosis. So let's try some of this in practice. So I showed you the paradigm, and so here's the patient. After obtaining more history, you learned that the patient does have chest x-ray documented pneumonia in the past 3 years. That chest x-rays shows demonstration of bronchiectasis. He has sinus surgery in the past for sinusitis. And so using that paradigm, what arm of the immune system be affected? And again, this is just kind of to warm things up a little bit.
Polls closed.
I'm sorry?
Polls closed.
Oh, I'm sorry. Well, sorry.
Still coming in?
Maybe because you answered very quickly.
Maybe I did.
Alrighty, so they'll start trickling in. And again, the majority of you recognize that this is a B-cell immune deficiency. Now, it doesn't exclude phagocytic immune deficiency. Again, this is just more likelihood and probabilities. So again, I wouldn't necessarily call that is completely incorrect. But again, we're picking most common, fitting what fits the profile or phenotype. And so the B-cell arm of the immune system is responsible, again, as producing this guy. So immunoglobulins of the different classes. And again, this was seen in the majority of respondents in the IDF survey. And so it would be the most important one for you to recognize because it's the most common one you're going to see. And so what is the pattern? How can we define it further? The pattern is recurrent cytopenic infections, typically the same organisms that's seen in a regular patient. Strep pneumo and H flu. So again, the type of infection won't be as helpful as much as the frequency and severity of the infections, with chest and sinus infections being important. Now, they can get chronic viral and parasitic infections, but a very narrow spectrum. Typically, it will be enterovirus or Giardia. Enterovirus can cause GI or CNS infections, and Giardia can cause GI infections as well. So again, the type of infection may be less helpful than recognizing the frequency of infections in B-cell immune deficiencies. So if we talk about the most common B-cell immune deficiency, it's worth talking about selective IgA deficiency because it is picked up very often. Blood banks have estimated that the incidence of selective IgA deficiency is about 1 in 500. But 90% of these people are completely asymptomatic. And again, the range is either 2 standard deviations below the mean or undetectable. Now, the manifestations, if you are symptomatic, is again the same pattern, sinopulmonary GI, and some patients can develop autoimmune disease as well. But I think we should really talk about common variant immune deficiency because that's the one that is most on our mind. It's the one that you probably see the most often. And again, it was the majority of the IDF population. Now, common variant immune deficiency, if you take the strict definitions, you have low immunoglobulins with poor specific antibody production and exclusion of other known genetic or secondary causes, which means that CVID is a clinical diagnosis and there isn't a specific gene defect that characterizes all of CVID. And so that's important because every CVID patient will be slightly different, all collected under these major features. But again, my goal is just to give you some idea of the spectrum of CVID, but not make an implication that every CVID patient looks like this, okay? So if you look at the complications associated with CVIDs, the best review article is Charlotte Cunningham Rendell's description of how she treats CVID in 2010. I think it's one of my favorite articles. And again, in her own cohort at Mount Sinai, obviously we talked about infections being the most relevant, and we talked about those infections, but some of the other secondary complications that are worth mentioning, other than lung impairment, is the development of autoimmunity, gastrointestinal disease, and lymphoproliferative or granulomatous manifestations. So what do I mean by that? Let's kind of dig into that. So lung disease and CVID certainly can cause by damage by recurrent infections leading to a bronchiectatic pattern. But interestingly, a subset of patients with CVID can get what we call a granulomatous lymphoproliferative type. And so they get ill-defined nodules. Sometimes they don't have very sharp borders. They kind of look like little hazy areas. And again, if you biopsy these, they can have different morphologies. I had one patient that was completely B-cell aggregates. And certainly they're susceptible to other features of interstitial lung disease as well. And so certainly this is kind of what worries me when I take care of a patient with common variant immune deficiency. I'm really trying to protect that loss of lung function that's so prevalent as a major complication of untreated or poorly treated common variant immune deficiency. And so some of these patients, other than immune globulin replacement, may benefit from antibiotic prophylaxis to address this. Now, when I mean lymphoproliferative, what I mean is that they have increased proliferation of lymph tissues in the usual organs, which would be splenomegaly or some sort of internal or kind of peripheral lymphadenopathy. And so when you biopsy this, it's very often that you'll get a report that says it has a granulomatous or sarcoid-like pathology. So again, that can be a little confusing, but again, you're really looking for some sort of dysregulated pathology in these nodules. And again, they can occur anyways. Again, now, we do know that patients with common variant immune deficiency are predisposed to hematologic malignancy. Now, how do you diagnose hematologic malignancy in someone who already has existing splenomegaly and lymphadenopathy? That's a good question. I'm not really sure. I think overall, if someone has symptoms that are suggestive of something beyond their typical course, you may need to look for clonality in their population. Autoimmune features are prevalent in a good proportion of CVID. And interestingly, it can precede, again, some of these features can precede the onset of recurrent infections. A patient we regularly follow in our immune deficiency clinic was given the diagnosis of ITP. He had thrombocytopenia requiring steroids or IVIG infusions. And then over time, he developed the infections. So again, it doesn't have to go in the same stereotyped order. It's only, again, when you start to get that pattern, you start to suspect congenital immune deficiency. And again, even though I'm citing autoimmune cytopenias, they can occur in any organ, such as endocrine organs. So lymphoproliferative manifestations can occur anywhere. So lymphoproliferation can occur in the gut. This can be a nodular lymphoid hyperplasia you may see on endoscopy. It can be associated, again, with lymphoma or carcinoma. They can get IBD or Crohn's-like manifestations. And again, they can get persistent diarrhea. And usually, if you get that history, you're probably going to want to look for Giardia. So I think I already talked about that. I apologize. So let's talk about selective antibody deficiency. So selective antibody deficiency is defined as a specific defect to the polysaccharide antigens, but they can respond to protein antigens. So if I look for vaccine responses to tetanus diphtheria, they're completely normal. But if I administer a Pneumovax and I measure a 4-week later post-titer, they do not meet criteria. Why is this important? Because they often have normal immunoglobulins. I want to bring the point that total immunoglobulins do not rule out the diagnosis of a humoral immune defect. You can have good numerical numbers, but poor quality. And I just really want to make sure we don't use total immunoglobulins as basically closing the door on a possible B-cell immune deficiency. So let's go to another case. So you see an 18-year-old with a history of inflammatory bowel disease on TNF therapy. And he has a 3-week history of a worsening tender neck mass on the right neck. And so an ultrasonography shows that is a lymphadenitis with pathology showing an infectious abscess with a minor granulomatous component. You try treating with antibiotics, it does not respond. And so therefore he's referred to an IND. And the culture from the IND shows Bravundamonas vesicularis. So Bravundamonas vesicularis. I've never heard of that organism before, but my understanding is, from ideas, they told me it was a gram-negative bacillus in a Pseudomonas family. And again, anti-TNF would not be expected to predispose to this infection. So you dig deeper. You get that unusual infection, you ask questions. And on further history, the mother tells you he had the same presentation of lymphadenitis. This time it was inguinal. And again, that was when he was very young in life. And so what arm of the immune system is likely affected in this patient?
Eggs.
Is it on? All right, I'm sorry. Well, anyways, again, at least you're kind of thinking about it, which is very important. Technology, who needs it? All right, so this is chronic granulomatous disease, a phagocyte immune deficiency. So chronic granulomatous disease, we know, is a defect in the killing of catalase-positive organisms by phagocytes such as macrophages or neutrophils. Again, the enzyme that's involved is called phagocyte oxidase or NADPH oxidase. And again, I told you the pattern before, but to remind you again, these are recurrent bacterial or fungal infections, and they can get inflammatory manifestations. So when I talk about GI granulomatous inflammation, that can be very reminiscent of an inflammatory bowel disease type presentation. And again, I'd make the argument that we don't really know what the immune defect that leads someone to react so adversely to their own bacterial flora. But so again, there are overlaps between some of these conditions. And again, we typically think of CGD occurring only in very young children, 2 to 3 years of age. But again, here's an example where there's always exception. I'll try to explain to you why. So again, pneumonia and abscesses are classic. So a large liver abscess should bring into the question, is this deep-seated abscess due to a phagocyte deficiency? At least you should kind of get your mind on why did this occur. We talked about lymphadenitis, but osteo may be a manifestation as well. And again, sometimes they may not manifest with the blazing hot fever you'd be accustomed to since they're immune deficient. Now, what's common in chronic granulomatous disease? Well, Staph aureus is very common, but actually, if you look at the most common cultured organisms, they're very unusual. Burkholderia, Serratia, Nocardia, Salmonella. They are also susceptible to fungal infections such as Aspergillus. So as a contrast for a B-cell immune deficiency, something like CGD, although Staph aureus is very common, an unusual organism that you did not expect might be more suggestive of a condition like this. So again, both patterns are relevant. Frequency, severity, and also the type of infection. So briefly, again, I can't really go over everything. I'd love to. We do know that this enzyme can take molecular oxygen and make superoxide, which is free radical. To stabilize it, superoxide dismutase will turn this into hydrogen peroxide, which is very good in disinfecting the phagosome once it engulfs bacteria. Myeloperoxidase will make bleach. So bleach is very good at getting rid of bacteria. And certainly these reactive oxygen species can also help with the assistance of known enzymes that, again, bind to the phagosome and dissolve the bacteria inside different proteases and so on. So how do we diagnose CVID? CVID is usually diagnosed by flow cytometry. The classic 1960s answer was the NBT test, which was a light microscopy-based test. Now what we are able to do is we have a dye that's able to detect reactive oxygen species and change color after you activate neutrophils with PMA. So in normal control, on an unstimulated group of neutrophils shows a general bell-shaped curve. If you give PMA, this bell-shaped curve shifts to the right because it all glows. It glows with the color of reactive oxygen species in the presence of dihydrorhodamine. So an autosomal recessive patient has less of a right shift, but not a complete loss of function, where an X-linked patient has very little function. So the type of subunit involved in chronic granulomatous disease can determine its severity and phenotype, with the argument that autosomal recessive patients with CGD are less severe because they do have some neutrophil function. Again, out of interest, the mom of an X-linked patient would have two populations. They'd have one X that makes normal oxidative bursts and one that is not able to. So again, I think that's very interesting. This is our patient. This patient particularly had this kind of smearing residual function of the neutrophil oxidative burst, but not complete loss. So again, he presented much later than you would expect. His first manifestation of Crohn's was around age 13, and again, I did lie to you. He actually presented to us at 17, but again, that could have easily been 18. So again, consider PID in patients with unusual or opportunistic infections. I'm going to give one more case. Again, I try to pack it in a lot, so I apologize to kind of go very fast. So you're taking over the inpatient service, and you're seeing a 29 previously healthy male. The guy never sees a doctor. He has a 5-day history of malaise, high fever, nausea, vomiting, and he has marked splenomegaly. He decompensates pretty quickly after admission, and he actually has to be sent to intensive care and respiratory failure. He is persistently febrile, and he is pancytopenic with a significant transaminitis. All your cultures that you send are negative. HIV and other infectious serologies are negative, and his parvovirus PCR is negative. You do leukemia and lymphoma panel, it is negative. Yes, he has some hypogam, but again, you can't find a bacterial infection. And so, a type of immunodeficiency was suspected, and a diagnostic blood test was ordered. Again, I didn't know I had enough time. I should have made a question about this. Anyone knows what this is? Yeah, This, again, is not very common in adults, but again, this happened in a Jewish hospital about, I think, earlier this year. And the key test was a ferritin, which was above the upper limit of the assay. Again, I didn't ask them to dilute it, but it was a ludicrously high ferritin level. Well, what's the big deal? Why is ferritin so important in this case? Well, here's a retrospective review of ferritin at Texas Children's Hospital. And a ferritin in the kind of thousands, 10,000 or above, pretty much would cross a couple diagnoses. Number one, hemophagocytic lymphohistiocytosis. Number two, who knows? All right, didn't make a diagnosis. Could this be HLH? I don't know. Number three, shock. Well, shock's not a diagnosis. What caused the shock? All right, I'd posit to you that the majority of these patients had extreme exuberant immune activation suggestive of hemophagocytic lymphohistiocytosis. And the authors found that a ferritin over 10,000 was 90% sensitive and 96% specific for this condition. So HLH is pathologic immune activation. It has a lot of similarities to sepsis. Again, sepsis is a cytokine storm due to uncontrolled infection. And again, the out-of-control viral infections that can occur in HLH can stimulate the immune system to a degree that you undergo a dysregulated and hyperinflammatory immune state. Again, the associations, at least with the familiar forms, is with a natural killer cell or the cytotoxic lymphocyte defect. Again, for rheumatologists out there, patients with existing rheumatological disease who have a similar presentation are called macrophage activation syndrome. But again, it is the same concept. Exuberant, uncontrolled inflammation. To understand this and to enroll in clinical trials, certain clinical criteria were developed. And again, you need persistent fever with splenomegaly and cytopenias. There are other markers of extreme inflammation, such as the ferritin. There's an activation marker for T cells called the soluble IL-2 receptor. And again, you can observe hemophagocytosis. Your own immune system will be eating itself. It will be eating red cells. It will be eating other bone marrow progenitors. It is an uncontrolled immune activation associated with a dysfunction and natural killer cell activity. Again, there are known pathologic mutations. It's beyond the scope to discuss all of them. But again, you can imagine that if you have a virally infected cell, different mutations in the ability to deliver two proteins, perforin, which forms a connection between a natural killer cell and target cell, and granzyme B, an important protein that will tell the cell to scuttle the ship. It'll tell it to kill itself. So a perforin mutation or any problem with vesicle transport, docking, or fusion has been associated with natural killer cell mechanistic dysfunction. They are not able to kill these cells, allowing viral infections to go uncontrolled. Now, this exuberant immune activation can lead to liver inflammation. Liver failure is a common presentation that should be in a differential. An unexplained liver failure and fever, neurologic findings. So we had a patient that presented last year with a seizure as her following a fever as her presentation of HLH. And again, the monovirus is what we usually associate with a lot of HLH manifestations, but other viruses can be implicated as well. Again, stuff like lymphadenopathy rash are less characteristic. And so again, immune activation, fever, splenomegaly, hyperferritinemia, and activation markers, and then pathology due to the cytokine storm. So cells will be destroyed by hemophagocytosis, and then cells will also be, the immune system will attack the liver, CNS, and other organs due to dysregulated inflammation. So fever unknown origin, acute liver failure, bone marrow failure, neurologic dysfunction, and again, that patient from Mediterranean with leishmaniasis that, just there's commonalities in the sense that it's very easy to send ferritin as a test. And so, again, I just kind of encourage you to consider that in your differential diagnosis for unusual presentation of some of these kind of fever unknown origins, or, again, especially in the context of cytopenias and liver inflammation. So this patient had an 80,000 EBV, and he had very decreased NK function. So he got chemotherapy to suppress the inflammatory response. And we actually killed all his B cells with rituximab to kind of wipe out the virus. So kind of to put it all together, all right, I'm sorry I kind of rushed through. I didn't go over every immune deficiency. I think you are very familiar with T-cell immune deficiency with HIV. And again, complement immune deficiencies are pretty rare, but again, you're going to think about recurrent night-zero infections. But the most important pattern you should be able to recognize is a B-cell immune deficiency, with frequency infections being the most relevant clue that this is something that works in immunoglobulin workup, maybe specific antibody titer testing. Now, phagocytics would be patients who have kind of deep-seated abscesses or lymphadenitis associated with granulomatous inflammation, and sometimes very unusual cause of bacteria. And again, I mentioned a very rare condition, but again, important to recognize, because, the treatment is actually chemotherapy immune suppression, again, which would be counterintuitive for someone who's febrile and having kind of a sepsis-like picture. So again, sending a ferritin is a very easy test to kind of screen for that condition. And so the workup, again, is always on the quantitative side and the qualitative side. Do I have enough of it, and does it work? And for B cells, you would get the immune globulins, and even if the B cell count is normal, because of selective antibody deficiency, you would still want to know they could respond both to protein and polysaccharide antigens, their TD and their pneumovax. With T-cell immune deficiencies, you can do lymphocyte subhops to get a CD4 count. You've done it all the time. And then again, this is probably where I'll be getting involved in ordering stuff. But again, I can stimulate T cells and see if they proliferate normally. Again, that is a functional test. Do they respond to Candida? Do they respond to tetanus? Do they proliferate in response to certain antigens? Phagocytic immune deficiency, I showed you a little bit about the neutrophil oxidative burst as measuring the capacity of neutrophils to generate hydrogen peroxide and bleach. Complement, the screening test, I didn't mention this, is a CH50. That's the ability of complement to lyse red cells. And then there's a natural killer cell function, the ability of natural killer cells to kill cancer cells loaded with chromium. It's a chromium release assay. So again, this is kind of the summary. If there's one thing I did want to emphasize is that immunodeficiencysearch.com is a good resource that has a lot of the things I was telling you, the general framework, and it actually will give you specific cases, and you can kind of play around with them. So again, it's kind of, I don't expect you to remember everything, but at least you know where to go, and at least know when to start asking questions. And again, we can do our patients a favor by diagnosing them early, preventing complications that again can cause permanent disability. So again, if you ever need help though, you can always call me. Again, I'm right by Norton Hospital. My phone number is 852-6633. You can always page me at any time. I'm in the hospital operating. They can have me paged. Again, I'm willing to answer your questions. Again, this is very critically important because we don't always think about a rare condition. But again, we should be very mindful to at least consider it and again recognize when it tips over into something that's common to something that's very unusual. So I'd like to take any questions if there are any. Thank you very much.
Jerry, thank you so much. This was outstanding, and I wanted to highlight to the trainees the number of things that you use for your lecture. The tone of your voice, the modulation, the passion, the bringing up cases, the simplicity of the slides, and the coming back to summaries. These are all classic of how to present to an audience to make sure that the message is delivered. So this was outstanding. Listen, I was quite intrigued, and I'm always concerned about this, but you highlighted it very well today. There's some of these cases that come with what appears to be a hyper responsiveness of the immune system and is in fact the opposite. And we worry about this, although not as much as we should, interstitial lung diseases. You presented a case of interstitial lung disease where without any other thinking about this, we probably would have immunosuppressed further this patient. Can you talk to us more about how to early on detect this before we do damage?
So, again, if you have a patient who has the diagnosis of asthma, right? Sometimes, again, I told you that was a very common label that these patients have preceding their diagnosis of primary immune deficiency. What is the evidence? Was that something that the patient told you? Was that something because they were short of breath and they got better with an inhaler? Data is very important. Chest x-rays are data, spirometry is data. So why would your patient have a non-reversible airway obstruction? That would be very unusual. I think it's underutilized, but again, data is very important to kind of separate the unusual with the usual. And again, I think most asthma patients should get a yearly, spirometry of some sort to monitor their progress. So, again, to kind of answer your question, when you're having someone and you're worried about preventing the onset of interstitial lung disease, right? The most important thing you can do is to, number one, know where they're starting from and monitor them very closely. Every single patient with CVID in my practice gets a yearly full PFTs with diffusion and spirometry and lung volumes, and anything unusual gets high-risk CT for sure. I don't want to expose them to radiation unnecessarily, but I'm so concerned about the onset of interstitial lung disease. It's critically important that we don't rest on our laurels and intervene as soon as we can. And again, data is how we protect ourselves.
Thank you. Questions? Yes, sir.
I realized that in one of the slides, those are the diagnosed in adults, but like 50% or so. I'm not sure that the number is correct. But the question is it that is delayed age of onset, or those of us in pediatrics are not doing a good job identifying some of these kids who probably have immune deficiency, so they kind of linger on until maybe adulthood and they end up with adult condition.
So, I think the question was, is it the pediatricians not picking it up? Do these patients just present later? I would say it's both, right? Again, I think, I can show you that the delayed diagnosis doesn't apply to just internists, it applies to pediatricians as well. But again, I want to assure you that patients do present later in life as well. Again, they don't declare themselves until you have enough evidence. Plenty of patients who just have ITP in teenage years develop CVID in young adulthood, again, when they pass the pediatric threshold. And so the patient will declare itself. And again, some of the patients I follow with just selective IgA deficiency, I follow them every year, and I continually follow their immunoclines because I never know which way they're going. Will they continue to deteriorate in their immune function, or will this just be a static, just selective IgA deficiency? We don't know that, but again, monitoring is how we protect ourselves from that.
That's a political wise answer, considering that Dr. Rabelais may find out what you said.
Thank you. That was very, very nice. In this last case, when you were making the presentation, it looked to me like Still's disease, just hepatic involvement, fever, all the other manifestations. The ferritins also are seen very highly. They have hemophagocytic components. Why is not the Still's disease?
So that's a great question. And so Alexei Grom at Cincinnati Children's, he's a pediatric rheumatologist. When comparing the natural killer cell function in patients with Still's disease and HLH, they're very similar, actually. And again, it's supported by microarray data. So how do we interpret this, right? Again, it is probably similar processes going on. Still's disease is thought to be some sort of autoinflammatory disorder. But again, I'm making the argument that Still's disease lies in some sort of autoimmune macrophage activation type domain, where HLH is usually thought to be more of an infectious trigger. But again, these are divisions we made. The same fundamental immunology may apply to both.
Yes, sir.
The ferritin comes from the liver, I guess. How does that happen?
Oh, the cytokine storm greatly increases its production. Again, this is a massive release of cytokines caused by viral stimulation that the immune system is not able to clear.
Questions? Yes, sir.
So I'm against controlling it. In functional GI disorders, there's more interest in mast cells, but massive infiltration. So, but some of these people have sort of a immune deficiency disorder, and if so, how do you work that out?
Oh, I'm so sorry. So I know you're worried about a population with immune deficiency. What particular population?
Functional GI disorders, when like you have functional diarrhea, functional vomiting, leg cancer contains intestinal.
So I'm sorry, that's a very difficult question for me to kind of relate functional disorders to immune deficiency.
Gary, you mentioned mast cells. Did you say there was some infiltration of mast cells? Could this be something that needs to be pursued as an immune deficiency? I think that was his concern.
Oh, I see.
If you see too many mast cells in the GI system.
Well, that's a very interesting question, right? Because, we do know multiple influences for the production of mast cells, right? So again, do you feel that population has been well characterized in the cause of the increase in mast cells? Mast cells are increased in a lot of allergic disorders, as you know. So eosinophilic esophagitis, we think of it as eosinophilic esophagitis. But there's a group in California who wants to call it mast cell esophagitis because of, a chicken and the egg sort of phenomenon. So again, we're only scratching the surface of what are the immune processes that lead to infiltration of a particular type of cell. Is that echoes of the primary process, or is that a secondary manifestation? And again, I'm not sure I'll be able to answer your question with enough satisfaction. I apologize.
Final question? If not, thank you very much. Have a great day.